call this meeting in order. It's great to have everybody back. This is a subcommittee on sport-related concussions in Canada of the Standing Committee on Health. Today we have from the College of Family Physicians of Canada, Pierre Fremont, Chair of the Sport and Exercise Medicine Committee. And from the Canadian Academy of Sport and Exercise Medicine, we've got Elizabeth Hobden, President-elect. So we're going to have an opportunity to hear from our witnesses now, and for all those that may be following these proceedings, through our portal, there is an opportunity also to make submissions to our committee. So we look forward to hearing from our witnesses now. Witnesses, you're going to have your time to make your statement, and then we will hear from the members with their questions, and we'll be in a rotational manner. So you hear from all parties. So we can start with Mr. Fremont.
All right, thank you very much. On behalf of the College of Family Physicians of Canada, I'd like to thank you for the privilege and opportunity to present the family medicine perspective around concussion. So I would also like to acknowledge the close collaboration of the Canadian Academy of Sports and Exercise Medicine and the Canadian Medical Association in the development of the brief and jointly submitted to this committee. First, I'd like to further explain my experience with concussion from a broad spectrum of perspective. Personally, I sustained 3 concussions in alpine skiing, soccer, and playing water polo. I also have a bunch of kids who sustained quite a number of concussions. So, sport medicine, as a sport medicine team physician, I was involved in concussion management from the international level competition all the way down to varsity sports and grassroots sports. I'm also involved in a number of current initiatives around concussion, the Canadian Concussion Collaborative, the Sport Canada Working Group on Concussion. And as an academic, I've been studying the implementation of concussion management protocol in high school level sports program. I've also been involved in the use of innovative strategy, namely massive open online courses for the dissemination of the good way to deal with concussion and support sport and school setting in the implementation of protocols. And finally, as a physician, I have seen patients with concussion from all causes, in all age groups, and at all stages of this injury. Now, before I can discuss the potential contribution of family medicine to address this issue, I'd like to remind some key background information. First of all, the simple principles of initial concussion management are clearly within the scope of family practice. Second, these simple principles, which are initial rest and gradual return, removal, of course, from danger, initial rest and gradual return to cognitive and physical activity, they will allow the vast majority, that is 80 to 90% of concussion patients, to evolve favorably within 7 to 10 days. So that's a very good reason to start with primary care. And over 85% of Canadians have access to a family physician. So that's not the perfect score, but that's a pretty good one. So the question is, can family physicians play such a role? So over the last decade, with increasing awareness around concussion, there have been constant medical education opportunities about concussion for family physicians. So there was a rapid increase. Again, it's not perfect, but it's available, and the expertise is increasing to deal with the following aspects of early concussion management, which are initial assessment and diagnosis associated with the standard initial recommendation that I alluded to. Then there is decision about returning to an activity at risk for concussion when things do well. And finally, assessment in the presence of persistent symptom, and that can involve referral at this point if you get out of the any given physician expertise with concussion. So the bottom line message here is don't be afraid to build strategy with a central primary care role for family physician. Another key aspect of how we can address the issue of concussion is empowerment. In the joint statement from the Canadian Academy of Sports Medicine and the College of Family Physicians, we state that key aspects of concussion prevention, detection, and management occur prior to as well as after the medical encounter, namely in sport and school settings. So we need to develop public health strategy that aim to support and empower school and sports settings in dealing with the day-to-day management of concussion. And sport medicine physician and family physician can play a role to support the implementation of such strategies. Also, as a family physician, I want to emphasize that Canadians of all age groups suffer concussion that occur in contexts often unrelated to organized sports, such as leisure, work, car accidents. These Canadians should also be considered in the way we address this issue. So in conclusion, I'd like to leave you with 3 key messages. The first one is that now that high-level sports and national sports organizations have received significant support to do better about concussion, our next steps should aim to improve concussion prevention and management at every level of sport participation, all the way to grassroots. We should consider concussion occurring in every context and age group. And finally, don't forget that family physician can and should play a key role. Thank you very much.
Dr. Fremont. And now we're going to hear from Ms. Hobden.
So I would like to thank you for having me here to speak to you today before the committee. I'm a sport and exercise medicine physician, and we're uniquely qualified and experienced in concussion management. Sport and exercise medicine physicians have been founding members of the Canadian Concussion Collaborative, and they've played key roles in the international concussion statements or consensus statements on concussion in sport. This is the international gold standard that physicians look towards when they're looking to treat a sport-related concussion or return a patient to play. They're also experts in the design and implementation of medical systems and protocols for sporting events. A diploma in sport medicine is granted after examination ensuring competence. There are still, unfortunately, many barriers for Canadians who have a concussion. I see too many patients, like the following one, who was required, she's a young girl, she was required to travel over an hour to see me. Her expectation, her mother's expectation, was that she was simply going to walk in, get a note saying she could return to hockey for the weekend, play her playoff game, and head back home. A concussion assessment takes 45 minutes or more. And during this assessment, we discovered that this young lady, who was very intelligent and was expecting a scholarship from MIT to become an engineer, was unable to subtract 7 from 100 and get the right answer. She really had no idea of her deficit, and nor did her family. So sports and exercise medicine and family physicians are able to safely manage most of these concussions like this one, because they do indeed get better. But what they do need is these patients need time. They need time to understand their injury, and they need extra support that we often don't see with other patients because they have a brain injury, which means that they can miss appointments, they can have difficulty coordinating their care. And that puts an extra burden on physicians who are trying to manage a full waiting room and have the financial reality of increasing burden of overhead. Qualified multidisciplinary treatment in their own area is extremely effective for these patients because the burden of traveling can actually increase concussion care, or concussion symptoms. So it's very important that they have treatment that's close to home. Appropriately designed community-based clinics with evidence-based care could help to alleviate many of these barriers. The reality is, though, that there are only 531 physicians in Canada with a sport and exercise medicine diploma, but all Canadians can benefit from their expertise through a public health style approach. There's no doubt that community sport medicines and family physicians are excellent resources for patients with concussions. However, using the integration of sport and exercise medicine physicians in the planning of sport events can empower people to have prevention, detection, and management of concussion at all levels. We've done a fairly good job at the elite level, that's coming along, but most of our participants participate at a recreational level, and some of our pediatrics, our children, are at most risk from concussion, so it's important that we hit all levels. The legislated requirement of medical expertise in concussions for the planning of sporting events and protocols at all levels would greatly benefit the health and safety of all Canadians. I recall a young patient that I had who suffered a tackle in a community football league. At the time, he didn't know he was concussed. His teammates didn't know he was concussed, and there was no protocol in place to address this within his context. I saw him several weeks later after his academic performance had started to decline, and he'd been suffering from headaches and feeling dazed and confused for several weeks. Unfortunately, this is all too common and regular to see in my practice. The reality is sport culture changes slowly, and it often does not include medical considerations. It's important that we bring this to light at all levels of sporting in Canada. The medical involvement in planning gives credibility to change within the sport and to sporting bodies or community bodies to say, you know what, we know we haven't done this way in the past, but this is why we feel it's important to make these changes. I want to make it very clear, though, that I believe participation in sports should not be discouraged. It should be encouraged. It's important for Canadians' health, and that any requirements should not put an undue burden so that people are unable to participate in organized sport. Canadians need to be active, and they need to know that they are safe being active, and that if they should suffer an injury, that they can get the best possible care. So thank you for your attention, and I look forward to the discussion.
Well, thank you very much, Dr. Hobden and Dr. Fremont. We're going to have an opportunity now to hear some questions from the members that they're going to pose to you. Just for all the members, I understand that we have a consensus. We're going to have a vote later this evening. Bell should start going off at about 6:05, and the consensus is that we would stay here till about 5 minutes right before the vote, and then just scoot up, vote, and come back down to committee. Okay, seeing everybody in the affirmative, great. So we are going to start our questions with the Liberals and Dr. Yolfson.
Thank you, Chair. Thank you both for coming. Nice to be among my peeps. I was an emergency physician for 20 years before doing this, and you made a great point about the number of concussions that happen in non-sports settings, but we all often tend to forget that. You know, we only actually use the word concussion for the most part when it's someone who comes in injured from a sporting event, someone who comes in having been knocked over the head and his wallet taken. You don't tend to think concussion, nor the person who fell and broke their hip at home. But it's a consideration. I think that's something that, although this is about sports concussions, I think that there's much that's applicable that we can apply to the overall treatment of concussions. So do you know if there's any public health approaches or to non-sports related concussions? Has there been any concerted effort to get that out there, or is the science still concentrating on the sports related?
There are two solitudes that we are trying to connect at this point. The world of mild traumatic brain injuries, which is often the term used to describe those concussions that occur in non-sport related contexts. The definition of that is linked to some objective criteria like loss of memory, loss of consciousness, and things like that. And it's a challenge to get people comfortable with the management of that injury, the recognition of that injury in non-sport related contexts as much as it is in sport related contexts. There's a lot of work to do. And we often see people who get that hip injury and the concussion that comes with it is not identified. So we need to do better about all of those cases. And there is no scientific indication that the physiopathology of that injury is different if you get hit by a soccer ball or if you fall on the ice. So it's the same problem, and we need to do better on both fronts. But I'm not aware that there is specifically a strategy to address that as a public health issue. But there's certainly a ground in the numbers that I gave you to address it in a stepwise manner, starting with primary care, because so many of those cases, if you do the basic simple stuff, will heal just by keeping them safe and gradually resuming activities. So that can be the basis.
Dr. Hobden, I know there's a lot of communication that will go from sports medicine physicians to places where sports are done. So whether it's community athletic clubs, semi-professional teams, professional teams, schools. What would you say is the current level of knowledge in the sporting community among the clubs? Would you say there's a good? Is their knowledge good generally? Would you say it's poor? It's a general trend.
I think it's very sport and club specific, to be honest with you. There's some pockets where people have adopted this. They've looked at, what they can do to prevent it. But there are a lot, and probably, I would hesitate to say the most, that don't address it, and it doesn't even enter their radar. It's not unusual for me to get an email across my desk saying, can you cover this event this weekend? We can't run it without a doc. And that's the first anybody has thought of medical or concussion. So these clubs don't have something in place, and that's really, unfortunately, not uncommon. I think at the elite level, we're getting there, where the national sporting organizations have their, policies. It is filtering down, but one of the difficulties is when you have the national sporting organizations, let's say volleyball, not every volleyball tournament is sanctioned by the national sporting organization. So they fall outside of that, and they don't get that education. And I think our schools are in that hole as well, and they don't necessarily get that information coming to them.
Okay, good. What would you say is the state of knowledge on these head injury guidelines among primary care physicians? So that would be, that would include family doctors, that would include emergency physicians, these sorts of things. Would you say there's, through Canada, is there a reasonably consistent level of knowledge from the physician point of view? Dr. Fremont, you might want to chime in on this as well. Do we have a long way to go in making sure that all physicians understand, when a primary care physician can say, well, yes, I can manage this, or no, that one I need to refer, these sorts of things?
I think I'll speak from the emergency medicine perspective, because I am an emergency physician also, and I'll let Pierre speak to family medicine. We're getting there. I think the challenge in emergency medicine is, I think most of the doctors have the knowledge and have the ability to initially manage a concussion. It's not complicated. It's make sure there's nothing worse going on, and then, advise them about rest and follow-up. What the challenge in emergency medicine is what Pierre alluded to, is that it's often forgotten. There's a primary injury they come in with. It's very obvious they have a broken hip, and it doesn't come to light until later that they're actually having headaches, because they may not have them right away. And so we're missing people there, I think.
I can say to the committee here and the witnesses, we feel very safe. We have many doctors here with us today. We're moving over to our next resident doctor, and that's the Conservatives and Dr. Kitchen for 7 minutes.
Thank you, Mr. Chair, and thank you both for being here. I appreciate that. Dr. Hobden, you talked about protocols. and you raised the issue, and it's. I think it's important that we have that issue because, as you just in answering the question for Dr. Olson, the reality is that when we're looking at people knowing the level that they're at, they may not see that concussion come in until 4 or 5 days after the event, and they may have forgotten about the event. As we know, we hear it's whether it's a sport or an everyday concussion, we see that all the time in practice. So, but when we talk about the sporting bodies, what would you tell us that we should be saying to these sporting bodies that they need to do? I mean, I come as a regulator background, so the reality is I would look to see how do we regulate these bodies to make certain that they put in these protocols. And I'm just wondering if you could expand on that.
I think they need to have a hard look at their own sport and look where the injuries are happening and what rules can be changed. But I think where sport and exercise medicine physicians can really add to that is looking to help with education and what do we do when we think we have a concussion? What is our policy for following that? And so I think, like I said, the reality is a lot of sporting organizations don't have medical at the top of their thoughts, and then all of a sudden they come up with a policy or a protocol that has had no input from anybody with expertise in concussion. And Pierre, I don't know if you wanted to add to that.
Dr. Fremont?
Yeah, I think the sorry. Go ahead.
Okay, I'll let you come back to that. And so one of the things that we see, for example, the CAHA came out with putting in mandatory trainers for every team and putting that on, so we have those on the benches. The reality is that that training program sometimes doesn't provide more than basic first aid. And that's a challenge when you're asking somebody that doesn't have a medical background or any type of healthcare background to all of a sudden assess someone who's been injured on the ice and make that decision. Granted, usually the statement is, go see your family doctor. But sometimes we're in communities where, as I mentioned to you earlier, I come from rural Saskatchewan, and we don't have access to those doctors. And as you mentioned, all of a sudden they call you up because we can't run this program because we need a doc there. Those are big challenges for the rest of the rural Canada, and so we want to make certain that when we talk about things here, that we encompass not only the rural settings, but also the urban settings as well.
About that, I'd like to loop back to the previous question. The CCC made a recommendation about that. CCC cannot make law, but we made a clear recommendation that was published that if you organize an activity at risk for concussion, you should implement a way to manage concussion. The same way you should have a security and prevention strategy in general, but you should consider your resources and say, how can I do as best as possible about concussion? And that level of resources will not be the same if you are on the World Cup Tour in alpine skiing or little ski club on the mountain by the city. You will have a doctor and an expert physiotherapist on the World Cup Tour, and you will not have any healthcare provider at the little ski club. But you can still do very well. You can implement awareness. You can find a way to consider if the kid was able to return to school prior to returning to sport. And there's a way you can address every aspect and say, with consideration for the resources of any setting, how well can I do? And I think that that's the process we are looking for, because we will never be able to have sport therapists and even less physicians present everywhere a sport event at risk for concussion is occurring.
We have a lot of primary healthcare practitioners that's set up, and we chatted a little bit earlier about this, but that set up programs and specialties within those primary healthcare programs, and they recognize that aspect of, for example, for sports injuries, and in particular when we deal with concussions, et cetera, not only in the assessment process, but also the treatment and the return to play process, and a lot of those, unfortunately, we're finding today we don't have the data to say how many injuries, how are we affecting it, but as we move forward with this, we need to recognize, would you not agree that we need to recognize that there are professions that do have those specializations, and that they should also regulate within their bodies to make certain that those people are the ones that are being these discussions are being discussed about and brought into the fold.
If we were able to screen from the whole denominator of all concussion that occur, that 10 to 20% that will evolve with persistent symptom, and focus on those efficiently right after 2 weeks, to make sure that before they make it to 3 weeks, a month, they are seen by those specialists, those people with expertise, whether they are physiotherapists with vestibular cervical expertise, chiropractors. We need to have multidisciplinary team that will provide the individualized treatment that people need at this point. So what we're suggesting is to have a stepwise process where we screen for those who are not doing well. We make the good decision at the right time to return to play those who are doing well. But we need to improve that access to the expert, and we need to save the access to these experts by not overloading these experts with the whole bunch of concussion, because there are not enough such experts. There will never be.
I think, too, I'd just like to add, I agree with what you said, Pierre, completely. We have to look at the reality that most Canadians, or many Canadians, don't have coverage for some of these allied health professionals who are invaluable, and that is a barrier, for sure.
Moving over to the NDP and Ms. Hardcastle for 7 minutes.
Thank you very much. Can you maybe elaborate, Dr. Hobden, a little bit on the kinds of things that are being recognized as perhaps a standard of care for people with concussion, certain specialties that are not covered, but that you can see as emerging?
When we, as Pierre said at the beginning, rest and then gradual return to activity is good for about 90% of patients. But there is about 10% who, after 2 weeks, still have symptoms. And so there's, chiropractors, physiotherapists, occupational therapists, athletic therapists, and am I missing anyone, Pierre, who all have great expertise in specific areas of concussion and know how to help people with specific problems, whether it be, you're having trouble with memory, or you're having trouble with balance, or it's neck. And they have the expertise to deal with that. I, as a physician, do not, give very many complicated exercises for your balance. I can give simple ones, but when you fail that first 2 weeks, you need something a little bit more. And, unless you have a private insurance plan, often that's not covered. Yeah.
Did you want to add anything, Dr. Fremont, to that?
Yeah, the public care for brain injuries is very limited. I'm talking mostly in rehabilitation, and all the resources are taken by the moderate and severe brain injuries. There is very little left for mild traumatic brain injuries or concussion. So that is a barrier to access care. And that is something that should be addressed, improving that access to care when you evolve with persistent symptoms.
Okay, and just going back to your organization, it's a collaborative. Tell me what your experience has shown you where we need to, as a government, facilitate perhaps more the evidence gathering or the data sharing so that you have effective regulations even down the road. I'll tell you, because we've had various testimony already. One group, Parachute, for example, that did the guideline for concussion. That information that evidence is evolving all the time. Then you have these silos. Then you have what stakeholders should be included. So I know that everyone is most comfortable when you do set regulations that it's evidence-based. So where do you think we could be facilitating that data gathering, data sharing, and evidence sharing? Or our opportunities?
Well, I think that what was initiated with the Canadian Concussion Protocol Harmonization Project, which was led by Parachute with funding from the Public Health Agency of Canada, I think that was the start of creating a centralized, validated, and hopefully continuously updated hub of information. And hopefully there will be more federal funding to keep that going and keep that updated, because what we used to have before that was the international consensus that is updated every 4 years. Next one will be in Paris in 2020. Then we need Parachute to have the resources to work with the experts and contextualize the new updated recommendation at that point and maintain that central hub. And the next challenge that you have is transfer of that information and contextualization in a broad spectrum of contexts that go from that elite sport, very resourceful, to grassroots sports, not resourceful. But they still can do well if they are supported to do the best they can with the resources they have. So that's the next challenge, is knowledge transfer and implementation, while keeping the support to that harmonization project that I think was a big progress towards avoiding the problem of Googling concussion and getting 2,000 results for which you didn't know what was good from bad.
Okay, so really quick, it's interesting that you say that, because, you know, if you go online to the Government of Canada, if you go to sports, it's a very different mandate for concussions in sport than there is for health, and this under health when it's sport and concussion, or maybe I think sport is sport and concussion, then the other one is concussion in sport. These nuances of language, and I think it's been pointed out, ultimately it doesn't matter where the concussion came from, but we're starting with sport. We have this I guess I'll call it social infrastructure. These stakeholders are here and have been working in elite sport. Can we leverage that? What do you think we could be leveraging?
I agree with everything Pierre said, and I think we have the knowledge. I think we have the evidence. I think we have to keep that coming so that it keeps getting updated and renewed. And then the challenge is really getting that down to more recreational levels without missing anybody. Because when you think of who's doing recreational sports, if you're in rural Saskatchewan, it might be your community association. And so if we just consider the national sporting organizations, we're going to miss a lot of sports. We have to think of schools, we have to think of community groups, we have to think of recreation centers, and how are we going to bring that knowledge that we have down to a grassroots level?
Thank you. We're going to be moving over to the Liberals now, and Madame Fortier for 7 minutes, and that'll conclude our first round with the members.
Merci beaucoup. Moi, je vais parler.
Thank you very much. I'll be addressing you in French, so if you need the headphones, please don't hesitate to do so. I'm terribly sorry I missed your presentations, your opening speaking notes. So if I say anything that would lead you to repeat yourselves, please, that's not what I'm trying to do. What we're looking to do here as a committee, and you've already heard our aims as well, and you've shared ideas related to them as so far, is to see what sort of legislative role we might play as members of Parliament, able to offer certain ideas that would help the government support the initiatives underway. We would also like to work closely with the provinces. From what I understand of the complexity of this issue, there is a role to be played by the provincial level of government as well as by the feds. I would like you, given that this is the last round of questions, to share any recommendations that you might have for us, things that we, as legislators, should look over. You've mentioned more funding, of course, but is there anything else that you haven't yet had a chance to say? Please go ahead, Mr. Frémont. All right, let me go back to a point that I did make earlier. We need to continue to support the good work that has already been done by asking that the Minister of Health and the Minister of Sports and people with disability to work closely together and come up with a national strategy. This is something that we need to support because we need to keep this up to date and we need to project this far into the future to stay on top of this issue of concussions in Canada. Then the second challenge that I referred to already, well, we had an interesting way to advance with the national sports associations. But we need to do the same thing below the upper level of sport, throughout all the levels of development of sport and athletes. We need to come up with new ways of reaching these people. I mentioned one that we are exploring right now, the massive open online courses. That's what we call it in English. It's a very good strategy for knowledge sharing. Are these offered in French? Well, the first massive open online course was given 4 times in French at Laval University, and that was our proof of concept. It worked very well. Right now, we're working up an English version with the University of Calgary. 2 weeks, we already have 4,000 people who've signed up for this course. So that's the type of new strategy that's on the horizon. Something else that's been much underscored in groups that I've worked with is the need to get better data and more data, and to oversee the data collection outside our normal sources of data. Our data banks right now on health are usually based on hospital visits, hospitalizations, and a little bit of outpatient work. What we need, though, is data from where concussions occur in sporting environments and sports venues. So that means that we need to extend our data gathering, and that will call for some funding.
Only thing that I would add or kind of emphasize is I think that we need help in some ways getting the attention of some of these sporting organizations. Like I don't think that they think about it, and it's not because they don't think it's important. It's just that they've always done this way, and it's the way it's done. And so it's a bit of getting into sporting culture. And so bringing that evidence down to them, I think sometimes you knock at the door and the answer is, no, we don't need that. So a little bit of a nudge in that direction might be helpful.
Thank you. I understand. Je voudrais peut-être, parce que...
We still have a bit of time, I hope, yes? Oh, good, wonderful. Are there any best practices or anywhere around the world that Canada might take into consideration and that you think that we should pay special attention to or look into? Because sometimes other countries do move ahead on issues of concern to us, and we can follow suit. I don't want to be too pro-Canada, but I must say that Canada is already respected as being a leader in the matter of managing and treating and identifying concussions. Many of the experts in this area are Canadian. There are some good moves undertaken by large sporting federations, though. For example, think of the rugby sector, the traditional rugby associations. They accepted changing a very fundamental rule, allowing a player to be withdrawn from the play to examine them. So that's a very good example. So there are ways to rethink how we go about practicing some sports to ensure that no errors are made, that concussions don't occur, or that we identify them quickly. So there are good examples from outside of Canada. That's good to hear. Would you like to add anything?
Federation is actually being held up as an example in the International Federation for their concussion protocol. And that goes, again, greatly against the culture of the sport. You get back up on your horse again. And they have accepted that, you know, you come out, you sit out, and you need clearance to go back in. So I think we are leaders. Yeah.
Merci. Thank you.
Thank you. And just as we move into the second round and the Conservatives and Mr. Weber, I just have a quick question. I know, Dr. Hobden, you brought up that you would like to see some rule changes when it came to sports. Do you have any clear examples of what rule changes, what sports should be changing some of their rules?
So I think it has to be done by the sport, and they have to look at their own sport. You know, my background is equestrian sport. I'm their national team physician, and it took 10 years for us to change that rule. It's the culture. It's slow moving, but it has to. I think it really has to come from within the sport. But I think they also need to be nudged to look at it and to say, "Hey, look, why is this happening in your sport? Why are your athletes coming in with the most injuries and the most concussions into our emergency rooms and that kind of stuff?" But I think for somebody from the outside to come in and say, "You're going to change your sport like this," I'm not sure how successful that would be.
Thank you. And over to Mr. Weber for 5 minutes.
Thank you, Mr. Chair, and thank you, doctors, for coming today to present. I guess I'll start with you, Dr. Hobden, and a comment you made in your presentation of a young man who got hurt, didn't know he was concussed, and so, of course, his academics declined and his headaches and his confusion were evident. So an individual, I guess nowadays, has an avenue. Back in my day, in the late 70s, actually, early 80s, I know for a fact that I've been concussed before, numerous times. Maybe not as many as you, Dr. Fremont, but I don't know. I don't know whether or not I was dealt a concussion or not. I was certainly knocked out. So being someone who assesses patients, how do you, and again, this is my first time at this committee, so my committee members have probably heard this before, but I have not. How do you assess whether someone has had a concussion or not? Being knocked out does not necessarily mean you've had a concussion, correct?
Not being knocked out doesn't mean you don't have concussion.
Yes. Yeah.
Okay, so it's a two-way street. It's a complex clinical assessment. You have to take into account the injury. Is it a mechanism that could potentially lead to a concussion? And then are there signs and symptoms that are consistent with a concussion? I think it's really important to note that there's no one test we can do to say, yes, you have a concussion. We can do CT scans and all sorts of magical things to make sure you don't have a more serious brain injury, but there's no one test that we can do.
Okay. And so you've assessed then that this patient has had a concussion, and I'm sorry again, you've probably heard this before, but the treatment then would be just rest and relaxation, or what would the treatment be for someone who's suffered a concussion?
So for the first 3 days, it's definitely rest and relaxation. And then we try to increase the activity level gradually. And in 90% of patients, in about 7 to 10 days, they will be asymptomatic and they'll be able to start a gradual return to sport or learning or work or whatever that is. There's a group who do not progress beyond that. And they're the people that Dr. Fremont was speaking about before, need to be triaged to some further care and specialists.
I see. And can you describe to me, Dr. Fremont, what that care would be then? What would you do then for these serious
At this point, when you
concussions?
have persistent symptom, what you need to have is a careful assessment of different spheres like the mood disorders that quickly can be part of concussion. It's very stressful, and anxiety can go on to depression. You can have cognitive problems in the cognitive sphere. You can have a problem with the vision and balance that can be affected. You can have components that come from cervical injury, whether that is a different injury or an associated injury, that's still being explored and studied. So, but at this point, the key message is you need to have the properly composed group of experts design an individualized treatment plan. And the message that comes with that is there is no one specialist or one technology that can take care of every concussion with persistent symptoms.
Right. Dr. Hopden, you'd mentioned also that there's about 531 Canadians who have this specialty that you both have. That to me sounds quite low, of course. So back to this young man who experienced this concussion. I guess he would just go to a doctor, his family doctor, and then they would then recommend that he see a specialist, which would then be you. Of course, the wait to get in to see you would probably be quite long, I would think.
It depends. It's
Depends,
variable.
yes. But I guess that's
Weber.
okay.
And we're going to be moving over to the Liberals now, and we are very lucky today to have, actually, this is a subcommittee of the Standing Committee on Health, and we have the chair of the Health Committee with us today, Mr. Casey, be asking a few questions.
Thanks very much. I don't know anything about concussions. So what happens in somebody's head when they get a concussion? What actually happens?
Well, you know that first period of rest that we recommend, that 48 to 72 hours? Well, the studies on the brain during that period using animal models and fancy imaging shows that there is a metabolic storm in the brain. There is a problem with the flow of ions in and out of the neurons. And so there's no focal anatomical bleeding or disruption, but at the cellular level, there is disruption, and there is a metabolic storm. There is high energy consumption at that point, and so it's complex, but it's the understanding of what's happening is evolving rapidly, and hopefully we might have at some point ways to act at that very acute stage through intervention, but that's not really possible at this point. The only thing we know is right to do at this point is to respect that initial period where we limit the demand, the physical and cognitive demand on the brain during that storm.
So when I slipped on the ice about a month ago and fell and hit my head on the back, it could have affected my whole brain, theoretically. It's not just where I hit.
Yeah, it could have been a very bad injury. Some people die from a fall like that, and because they develop a brain hemorrhage that can be sometimes slow, sometimes fast. But most people will have a concussion with that type of more diffuse cellular perturbation that will last for a few days with the related symptoms.
What about the cumulative effect? If a person has one concussion and then a second one, is it if the event is the same, is the concussion worse for the second one and for the third one and the fourth one?
I would say that mostly depend on how well you were able to heal from the first one. Uh-huh. The worst case scenario is when you get injured prior to full recovery from the first injury. That's when you see the very dramatic and sad cases of kids who die from recurrence of a head injury, while after returning to play before being asymptomatic. So that's what we don't want. And there is more and more information that on the spectrum of what I just described, without dying, you get those very bad and long-lasting episodes of concussion when you get re-injured prior to healing properly. And on the other side, there's no real indication that if you sustain one concussion, heal it very well, make a successful return to the sport you love, that you will have a residual weakness.
It was really important to get the diagnosis right at the time of the first injury. If it's not diagnosed right, then the second concussion could be much worse.
Yeah.
Now, you said you had concussions. What are the impact of those concussions now? Do you have an impact now from them?
I probably had the chance to be quite well informed as a physician when I had those, except maybe the one when I was younger playing water polo, but I don't remember any consequence of that. I was probably able to heal. I had the chance not to get re-injured over that first injury. The two subsequent concussions just healed with making sure that I didn't get re-injured and rested, and then gradually resume my activities. So I don't feel I have any sequel of 3 concussions.
Mm-hmm. Well, thanks very much. That's good.
Thank you, Bill. We're going to be moving over now to the Conservatives and Dr. Kitchen again.
Thank you. And I appreciate your comments from the questions from Mr. Weber and from Mr. Casey, because I think a lot of times in this committee, there are a lot of people who don't understand or really how we walk ourselves through the injuries and what we see. And while Dr. Olson and I might have some experience in that avenue, a lot of our colleagues don't. But I appreciate those comments. As we roll with that, and I want to sort of keep on that subject of one of the things that we see in sport now, the aspect that we're dealing with the SCAT-5 and the child SCAT. And again, I'm going to ask you, while I may understand it, if you could relay that to my colleagues as to your approach to the SCAT-5 and the child SCAT-5.
The SCAT-5 is the Sport Concussion Assessment Tool. It's not actually its 5th version, but they called it the SCAT-5 for other reasons. But it's the document that comes out of the International Consensus Statement on Concussions in Sport. There's a narrative that you can read with the evidence behind it and all that kind of thing, but the SCAT is what we as physicians use to assess a sporting concussion. So it starts out with very simple things. What's your name? What's the date? What sport were you playing? What's the score? What quarter are you in? And it moves on to more complex things like asking you to do some memory tests of short and long-term memory. It asks you to do some balance tests to see how your balance is affected, because that's very often affected in concussion. And then there's some concentration aspects where you ask them to subtract, 7 from 100 and keep going. Lots of people have difficulty doing that with a concussion or saying the months of the year backwards. And when you've tested this, you can test some of their movement as well. And you come up essentially with a score, and the score doesn't tell you whether or not you have a concussion, but it can help me as a physician. The other thing that's part of it is the patient rates their symptoms. And so as a physician, I can say, okay, overall, I think things are improving. It's designed really only for the initial assessment to see where you're at, but certainly the self-reporting of symptoms is important as you go along.
Great.
Yeah, about 2.5 minutes.
About 2, okay, thank you.
2 minutes, yeah.
You did make a very important, both of you did, an important point that no one concussion is A, the same, B, treated the same, and C, comes out with the same results. And I appreciate those comments, because that's an awareness thing that we need to know, and that we need to get out for the sporting bodies to understand that as well, because they extrapolate that all into saying, well, and in the old days, they used to look at it like in my day when I had my concussions, your bell was wrong, get back out there. It's a long way from the heart. Whereas today, we need to be very well aware of that aspect of it because of the implications of it. And no one ever recovers exactly the same way. And while I was the victim of a hit and run when I was 16 by riding a bicycle and hit by a drunk driver, and was unconscious for 10 days. The reality was that I've come back from it, and it took time for that. And you see everyone recovering on those aspects. So when we deal with children, they're reliant upon the people around them to make their decisions. And that goes back to, as you talked earlier, to recreational sporting before they get to that elite level. As they get to the elite level, they have usually have a lot more professional help that's providing that for them. So what can we say to those that might be listening today, the parents that might be listening today, as to how they approach the aspect? Because a lot of parents will panic and maybe overdiagnose it themselves because they read it on the internet, or they may not do anything. And I'm just suggestions from you, if I could.
I think, the first thing I would suggest, if I understand your question correctly, is, what does the mom do who has a child participating in sport and is worried about the risk of concussion? I'd talk to her sporting organization, talk to the coach. What education does the coach have? Does the coach, there are free online courses, sporting organizations give these courses. So does the coach have anything? And I think that's a good place to start. And the second thing is there's lots of good information for parents on the internet from things like Parachute about concussions and how to recognize them and what's going on. And the reality is, if you're concerned about the health of your child, if you're concerned about a concussion, then, we always say, when in doubt, sit them out until you can get a proper assessment to understand what their health status really is.
Thank you. We're going to be moving over to the New Democrats for about 2 minutes or so before we have to scoot up for a little break here for votes, and this will conclude our first witnesses.
Okay.
Ms. Hardcastle.
Okay. So, we have a Canadian Standards Organization that has the authority to constantly monitor and to regulate or to set standards. Do you think we need to be exploring that kind of concept in terms of monitoring or assessing, I don't know, at some point down the road? Are you concerned the more you learn and the more you, there are a lot of silos, and how do we bring this together? Do you think maybe we should be looking at a central organization or something? Just finish up with your thoughts on where you think this really needs to go.
I think that notion of a central hub of information with tools to support every type of setting in the implementation of those recommendations is the key here. Implementing formal expectation, whether it's through regulation or legislation, those are different means. I'm not the one who will choose, but I think it's okay to, for example, for Sport Canada to associate funding. They do it for harassment. If you don't have a harassment policy, you don't get the funding. Why not do it with concussion? Why couldn't we say, if you want to organize a sport at risk for concussion, you must have a rule or you will not get that type of support from us? So, there are different ways to reach that, but this has to come with the support to meet the expectation, which is often a problem. If you just pass a law and you don't support the people to meet the requirements of the law, and you don't have the resources to verify the application of the law, then you just have a Damocles sword hanging there just to be able to say somebody is guilty when a kid will die, which is not right. If you implement an expectation, you need to have the support.
I think that's really important too. because Canadians aren't active enough. And so what you don't want to see happen is that things are put in place, regulations are put in place that people can't meet. And then there's less participation in sport. So they really have to have the support so that they can achieve these goals.
Questions and answers and recommendations from our witnesses. We want to thank Dr. Fremont and Dr. Hobden for being with us here today. We look to have this report ready to be tabled by, I guess, the end of spring. Yeah, by the end of spring. And we thank you for appearing here and for your testimony. Thank you. We're going to break now for about 20-ish minutes for a vote. I'm glad everybody is back, and apologize for that break for the vote. We are back now with our second panel of witnesses, and from the Canadian Concussion Centre, University Health Network, Toronto Western Hospital, we have Dr. Charles Tater. We also have with us from the University of Ottawa, Brain and Mind Research Institute, Sean Marshall, Division Head, Physician Medicine and Rehabilitation. And for the Center for Rehabilitation Research and Development, Dorothy Ann Curran, who is the Research Associate at the Ottawa Hospital. Just before, as we get started, we are going to start with Dr. Charles Tater. Just in case something happens with our video conference, we want to ensure that we get Dr. Tater's statement testimony here for the members to hear. Then we'll move into our other witnesses, and then we'll hear from the members the questions and answers. Okay. Thank you. So, Dr. Charles Tater, the floor is yours.
Well, thank you, Mr. Fonseca. I'd like to thank the committee for inviting me to speak. I'm very pleased, in fact, that this committee of Parliament is putting so much energy into the field of concussion. I've been focusing on this field in my practice and research for the past 20 years, and I think it's great that our country feels that this is a major concern. It has been my view for a long time that concussions are a major public health issue in our country for a number of reasons. We do generate a lot of concussions because of the way in which we live. We drive quickly, we play a lot of high-risk sports, and in fact, we generate about 200,000 concussions annually, and I can tell you that our research shows that about 20% of them do not recover within the usual time of about a month, and in fact some never recover. So we've learned quite a bit about concussions, and we're impressed with the fact that they are often followed by significant issues like major mental health disorders, and in fact, some end up with brain degeneration, as I'm sure you are aware. I think it's important for this committee to have a perspective, and probably I'm the oldest person who's going to speak to you. So from my perspective, a lot has really gone on in the last 20 years. So I welcome this committee to the team to deal with concussions, but I really feel it's important for you to be aware of this perspective. Beginning in about 2000, when the Canadian Academy of Sport Medicine, and you just heard representatives from that committee, put out one of the first concussion guidelines of any country. So Canada was really quite forward in saying in the year 2000 that every concussed athlete, for example, should be removed from the game or practice and should see a medical doctor. The following year, for about the next 10 years, there were concussion road shows that went across the country, visited all the major cities, sponsored by a number of organizations, including Hockey Canada and Think First. We opened what I think is Canada's first comprehensive concussion center, focusing on concussion care and concussion research in about 2010. There are now several others all across the country in major cities and even some smaller cities like Barrie, Ontario. In 2011, up until 2019 to the present time, CASM has had a Canadian concussion collaboration with a number of organizations, which now includes Parachute Canada, which is Canada's injury prevention agency. In 2012, in the legislature in Ontario, for the first time, a concussion law was given first reading, but it did not pass. And just to put that into perspective, by 2014, all 50 states in the U.S. had already enacted some form of concussion legislation. In 2013 was an important year because the first Canadian cases of CTE, the dreaded brain degeneration related to repetitive concussions, was first reported in Canada. And that same year in 2013, Rowan Stringer died in Ottawa from concussion-induced second impact syndrome following concussions in school-based rugby. The following year in 2014, the Ontario Ministry of Education enacted PPM 158, which was a concussion policy procedure for school-based sports. So it only covered school-based sports, but it was very important to do that. And in 2015, your Prime Minister Trudeau's mandate letters to the federal ministers of health and sport, Jane Philpott and Carla Qualtrough, respectively, he mandated them to support a national strategy to raise awareness for parents, coaches, and athletes on concussion management. So very, very important initiative in 2015. The same year, the Rowan Stringer inquest was held and established that that was a concussion-related death, and that jury recommended 49 measures to prevent further deaths in sports. The following years, the Public Health Agency of Canada awarded Parachute Canada with a contract to harmonize concussion education and guidelines for our country. The following 2016 to 2019, the Federal Ministry of Sport working group on concussions, headed by Jocelyn East and Michelle Fafard, began work, and that has been an excellent committee with representatives from sport, health, education, prevention, great committee work on harmonization and dissemination of guidelines. 2017, of course, was when the Rowan Stringer Committee formally called for concussion legislation, and I'm very pleased to say that that was ultimately enacted in 2018 in Ontario. So that's very recent, and now we are aware of other provinces, especially Manitoba, moving in that direction. Of course, Parachute Canada and FAC introduced these excellent guidelines. So we now have guidelines written by Canadians for all sports. So I think it's important for your committee to know that and to appreciate that.
Thank you, Dr. Tater. Thank you very much. And we've come a long way over 20 years, but we still have much work to do, as we know from the witnesses we've heard from this committee. Right now, we're going to be moving over to Dr. Marshall for 5 minutes. Thank you, Dr. Marshall.
Oh, great. Well, thank you, Dr. Tater. That was a great presentation and great history. And I think that, I think Dr. Tater precedes me in age. I'm also of a similar ilk that I think we predate concussion being a concern. And that early on in our careers, when we started off, concussion wasn't identified. I'm going to focus in my presentation and what I bring to your attention is kind of, I think the emphasis has been on identification and prevention of concussion. And where we have come into the fold and where we've done a lot of our work is on, I think, something very important mentioned by Dr. Tater, which is actually the management of concussion after it's occurred. So there's the acute management, and there's that minority of persons who've had a sport-related concussion or concussion outside of that. Generally, 15 to 20% in a study for pediatric, it actually exceeds 30% if we go greater than 30 days. If we only look at a short term of 30 days, if we go upwards of even beyond, say, 6 months, probably 15 to 20% of the population. Again, sport concussion is a subset of concussion, and I think it affects everyone in their daily lives. The tack on which I take from it is that we are recognizing that persons were having concussion as clinicians, and these individuals weren't necessarily completely recovering, which is what the expectation of concussion was for complete recovery. My main area has been moderate and severe brain injury, and we are actually in rehabilitation and finding that these patients were not completely recovering. So in akin to guidelines that talk about management of concussion, sport concussion, where clearly Canada has been a lead. Another area that we have focused on has actually been management of symptoms following that, to try and standardize practice for how we manage people who have ongoing symptoms following concussion, for primarily focusing on those with persistent post-concussion symptoms. Through the work of the Ontario Neurotrauma Foundation, there have been two sets of guidelines created, one for pediatric, ages 18 and under, and then again for adult. These have been published nationally, internationally, and been presented as such and are recognized as very solid guidelines. We're currently in the third edition for the adult concussion guidelines. The aim of this is to standardize practice, to provide care to, as Dr. Tater mentioned, 200,000 Canadians per year who sustain concussions. If 20% are not better by 30 days, then we're looking at people who need help and support. This needs to be improved in care and where we're focusing our research. The other thing I will comment on specifically is there have been initiatives that have, as to date, not been successful, but have tried to harness the expertise here nationally in the country. Led through Calgary, through Keith Yates, there was an application for a National Center of Excellence for Concussion Management through the University of Calgary. Not successful in the letter of intent stage, but it was harnessing experts throughout the country to focus on sport-related concussion and concussion in general, both pediatric and adult. Second, another initiative that's been successful but has not received full funding through the Ontario government, through the Ontario Brain Institute, in relation to the CONSORT group, the CONNECT group, in relation to studying concussion from all elements, from pre-concussion to concussion, looking at even chronic traumatic encephalopathy through all stages, including acute management and post-concussion management. These are things that should be pursued further to standardize practice of care. Clearly, Canada, Ontario are leading in this area in trying to set these standards, and this has been well recognized internationally. I believe that support on setting those guidelines and standards and allowing for further research will help us better serve our patients. Thank you.
Dr. Marshall, and now we'll be moving over to Ms. Dorothy Ann Curran. I know, Dr. Tater, I'm not sure if we cut you off at one point, but if you do have more to your opening statement, you can submit that. We will distribute that to the committee members, and it will be made public. So thank you.
Thank you.
Now over to Ms. Curran.
Hello. So concussion, and in particular sport concussion, has become very topical in terms of public awareness over the last 15 years, and both of the physicians have alluded to that. Research on concussion has also risen exponentially. In doing the literature review for the 2012 adult version of the guidelines for mild traumatic brain injury and persistent symptoms, there were about 18,000 abstracts that were reviewed. When the third version of the guidelines was created in 2018, over 38,000 abstracts were reviewed. So there's different types of research targeting different aspects of concussion. There's research on identifying concussion conclusively and quickly. Not everyone who experiences an impact to the head actually develops a concussion. So how do we identify those people who actually do end up with brain damage? There's looking at proper healing timelines. There's the guidelines, which are designed to advise people getting back to work, to school, to play for adults, children, and adolescents. There's a lot of research that's been done looking at attempts to speed recovery during concussion. So in the subacute phase, to address specific symptoms such as headaches, cognitive issues, vestibular issues. People want to get back to their day-to-day activities as quickly as possible. Some research on persisting symptoms has been done. So how do we identify people who might develop persisting symptoms? We know, for example, that women tend to have persisting symptoms more frequently than men. What can we offer these people in terms of rehabilitation? What therapies or treatments might offer optimal management for these persisting symptoms in the long run? There's also research that looks at extrinsic and intrinsic factors that might contribute to persisting symptoms. So there's a concern about the effects of multiple concussions, and this may translate to persistent symptoms. There's mechanism of injury, gender, age, which could possibly contribute to persisting symptoms as well. So not only are some athletes working in a job that can increase their likelihood of having concussions, it's known that people who experience a concussion are more likely to have another one, which is also a danger for athletes, especially those who are in contact sports. So it's generally accepted, as Sean and Dr. Tater mentioned, that about 15% of people who experience a concussion may go on to have persisting symptoms. And it's becoming a little bit more clear, actually, that could actually be a higher number. So maybe 20% of people end up with persisting symptoms following a concussion. And symptoms that remain beyond 3 months are considered persisting symptoms. So people who fall into the persistent symptoms category are at a great disadvantage. Their symptoms interfere with work, with return to play, with their social activities, with their family obligations. So in terms of avenues for future research, which is kind of more of where my focus is, augmented reality and virtual reality are definitely gaining interest in terms of assessment and treatments for concussion. There's different types of goggles with analytic software, which are emerging for use in sports, which are very portable, and they may be able to assist in diagnosis of concussions. Virtual reality using larger systems, which are more immersive, can also measure range of motion and center of balance, and they have good potential, though they'd only be available at healthcare centers. The newer gaming platforms make simulation interfaces more visually engaging, which could improve compliance for treatment. And the use of VR for assessment and therapy advantages are that we can program virtual reality very specifically to elicit responses based on increment or difficulty or intensity. And we can measure responses to stimuli. It's also a great distraction, and obviously the entertainment feature is high. In terms of the disadvantages, we don't know what long-term exposure to virtual reality can do. Virtual reality is also not the real world. So human responses are not the same in virtual reality. If we want to rehabilitate people into the real world, there are some things that we simply want them to do in the real world. If we want them to stack blocks in virtual reality, they might as well stack blocks in the real world. So overall, there's a lot of research that's being done on concussion. And at this point, the literature, in my opinion, needs to be really evaluated. Studies need to be evaluated by people with clinical and research experience using reporting guidelines that will help to qualify the research. And it needs the new research that is going to be done needs to be driven by what gaps exist that we know about now.
And I know that the members are eager to ask all of you many questions, to tap into your expertise and your knowledge. And we're going to start with the Liberals with Dr. Eyolfsson.
Okay. Thank you, Mr. Chair. Thank you, everyone, for coming. I was explaining this to the last panel. I'm a physician myself, so it's kind of nice being back with the people from my field. Feel like we're getting the band back together. So I'd like to start with Dr. Tater. Your center, they talk about they're studying deterioration of brain function, and does this correlate with, I think you mentioned chronic traumatic encephalopathy in your remarks. Has your research found any correlation with other identifiable neurologic conditions, for instance, dementia, Parkinson's disease, MS, anything like that?
Yes, those are very good questions, because there's a real connection between all of the neurodegenerative disorders. And patients may end up having more than one. For example, in the brains we have examined of athletes who have had multiple concussions, we have found other conditions present like Parkinson's disease or small strokes or loss of blood supply to the brain. So that's why very careful analysis has to be done of people who are suffering from symptoms like dementia and other brain degenerations to figure out exactly what caused those. And we're at a very early stage of this. In our center, we've examined about 45 brains now that have been donated to us by the loved ones of people who have passed on, where something of that sort was suspected. And in about 1/3 of those people, we do find evidence of CTE. So it's not as common as has been reported in other centers. Some are saying that up to 95% of brains donated to them concerning patients who have passed on with those degenerative conditions have shown CTE, but that hasn't been the case with us. And I think that that's just indicative of the fact that this is a field that is growing. We're just really scratching the surface, but we have made some gains, and I would hope that one of the objects of your committee will be to advance further research, as just indicated by Dr. Curran.
All right, thank you. And further to the examination of brain tissue. Now, you know, you've described how in these patients who have you find these things like Parkinson's disease and this sort of thing. In the absence of any of these diagnoses in the brains you've examined, is there any specific changes to the brain that you've seen that's unique to concussion that doesn't fit any other diagnostic criteria like Parkinson's or something like that?
Yes, very definitely. The diagnosis of CTE, or chronic traumatic encephalopathy, has definite criteria. For example, you have to see deposits of this abnormal protein called phosphorylated tau. And it's quite easy to identify that protein because it stains a dark brown with the appropriate stain if the brain is prepared according to established techniques now. So yes, we can identify brains that have that problem specifically. For example, Steve Montador, you may know that name. He played for 6 NHL teams during his career, and we went over his records very carefully. And I personally counted that he had 19 documented concussions. He was a very aggressive player, and his brain, when he died unexpectedly at the age of 35, had lots of deposits of this abnormal protein, which is very specifically located in areas that are characteristic of CTE. So the answer is yes. There are some people, even young people of 35 years of age after multiple concussions, are showing this abnormality.
Thank you.
Okay, thank you.
Moving over to the Conservatives now, and Dr. Kitchen for 5 minutes.
Thank you all for being here. I appreciate that and bearing with us on a day like today. It's great to have researchers here because now that's piqued my interest on a number of questions and aspects that I like to hear about. And I'm just trying to figure out where I want to start. But when a number of you talked about aspects, for example, with seeing brain degeneration, some of the side effects that we might see with mental health issues or possible CTE, etc. And I'm just wondering, is there research out there to actually say now, compared to my day, and I go back days when I was I could talk about my undergraduate degree, and I studied under Dr. Pat Bishop at the University of Waterloo, and he was a mentor of mine, and we did research where we were dropping hockey helmets with the ancient contraption. And Dr. Tater, I see you smiling. I know you're very well aware of this information, but nowadays we're seeing a lot more new information. And Ms. Curran, you mentioned about virtual imaging, and so these are all interesting aspects that I haven't kept up with, and I'd love to hear a little bit more about it. So on the issue of looking at, for example, for this protein, for the tau, obviously this is a new study. It's new. It's obviously done once someone's passed away, and we can't do it today to say to look for that product. It's an after the fact. How do you take all of that information and correlate that with a sports concussion? And I'll throw it out to Dr. Tater first, and then go from there.
Well, that's a great question, and I will try to answer it. It's a tough question. And by the way, I interacted with Pat Bishop for a long time, and he was a great Canadian researcher on head injuries, no doubt. But with respect to your question about tau and the fact that we can see it at autopsy, but the good news that is starting to appear is that research has shown us a way to identify it in the living. Now, we're not ready to be able to apply it to an individual patient who's suffering, let's say, with dementia, and you want to know whether is this regular Alzheimer's disease or is it CTE. So we're not ready for that. But I think that is coming down the pipe, that we will be able to identify it in the living. And one of the hottest areas of research right now in this condition is the use of PET scanning, which can identify deposits of this abnormal protein. We use a radioactive tracer that's labeled with fluorine 18, and we inject it and then do PET scanning, and we can actually see deposits of tau in the brains of some of those athletes in life. And we've had a very good relationship with the CFL Alumni Association. They've sent along a number of their alumni for examination with this technique. And we can actually identify deposits of tau in the brain of people who are living. So I think that's a very important first step in trying to develop a treatment for this, because we don't want to just be able to diagnose it. We want to be able to do something about those deposits of tau.
Thank you. And I know at the University of Ottawa they have a scanner now that is there, and it's been involved with our veterans in looking at PTSD aspects, and there's some early research on that aspect. And perhaps Dr. Marshall, you might have some information that would correlate with this.
Talking a little bit about different things too. So there's the one goal of identifying CTE, which is kind of a chronic sequelae presumed due to multiple concussions. I think the research is certainly going off in that range, and we're learning more and more each day. And I think that those things are very important. I think the other area, which is high intensity research, which is really what they're looking probably more at the sport level and the acute concussion level, is the immediate diagnosis of concussion. So, for instance, and that relates to what you're saying about PTSD. So often associated with injury, more often outside of sport than inside of sport, there's an emotional reaction that we often talk about PTSD, and some of the symptoms can be similar to those of concussion. And the other thing is we're looking for markers, or biomarkers, if you will, that would suggest that you've actually had resolution of your concussion. When is it safe to return? Point in case would be an example like Rowan Stringer. Clearly, a person, when they went through and looked through the record, had evidence of concussion, and that continued to play. Now, through prevention and other strategies in this day and age, we would, first of all, identify it, and that's probably where one of the many failures that Dr. Tater is referring to in the system occurred, and we need to remedy. But it would be ideal to identify those who actually had a concussion urgent injury. There are, experimental imaging techniques. Conventional imaging, such as CT or MRI, generally shows normal, or we consider it actually more severe brain injury. It's not normal. However, we do know certain MRI protocols like diffusion tensor imaging and other types of protocols, SWI imaging, can show concussions acutely. The problem is it can't be used diagnostically at this time point. But these things need to be explored. There are also biomarkers such as SP100, which if it's more severe cases, better pick up, but in the kind of milder cases, won't pick up. So I think for the acute markers.
Thank you, Dr. Marshall. Thank you. We're going to be moving over to the NDP and Ms. Hardcastle for 5 minutes.
Okay. Thank you, Mr. Chair. Actually, I would love to hear you continue, Dr. Marshall, with regards to how we sort out and monitor the progress that's been made for diagnosis and treatment, and then moving on to the more long-term effects that Dr. Tater was talking about, the intensity of that kind of research. But looking at from the mandate of this committee, which we're not really clear on what is going to manifest itself from the testimony and the report and the recommendations, how can we be facilitating some kind of not just about advances in research, but also the protocols that are needed and the standards and all of it. So,
well, it's a large topic, and I realize there's a time limitation. And in relation to concussion, I guess the fact that we're focusing on sport concussion, I think we have to first compliment the Canadians, as Dr. Tater was referring to earlier, who actually led the guidelines in identifying. First of all, identifying it, and then it's return to play protocols. Because you're saying, how do you do it?
Okay,
we're all looking for.
I guess what, just to clear, just because our time is limited, how about share what you know that would be best places for us to look at how we leverage what you've already done to move forward, and how we can facilitate that.
If you wanted to leverage where I think things are at the point where we've identified as a priority, it's been very important. I think research is where to go. I think that the truth is that you have a lot of very great researchers in this country who've actually come together. This is unique compared to other countries working for collaborations, as I mentioned earlier, for a National Center of Excellence. And I think that through big data, through, for instance, the Ontario Brain Institute, us being able to examine these large populations coming together should be able to identify technologies that can diagnose concussion and actually monitor progression, so we know who are at risk. And I think that this is going to be key to us being successful at kind of helping solving the diagnostic and then actually treatment. So I think that these collaborations to foster those and foster that research in our collaborative atmosphere in the country would be huge.
Okay, and Dr. Tater?
Well, I think that's very important, what Dr. Marshall just said. I would like this committee, this House of Commons Committee on Health, to put some teeth into what has been done to date. For example, I feel very strongly that every province should enact concussion laws, because that's one way to be sure that we're all on the same page with concern about concussion. The concussion laws should apply to not only school-based sports, but all the non-school-based sports. For example, all those that are organized by Hockey Canada, by the Canadian Soccer Association, etc. All of those folks should be subject to the concussion laws. And what do the concussion laws say? They say that everybody should be educated about concussion. They should know how to recognize concussion. And that goes for parents, coaches, teachers, the players themselves. The referees even have to be clued in about concussion. We simply have to prevent. We have to prevent people like Rowan Stringer from ending up dead. So concussion laws, we need accurate surveillance data. That's been recommended to your committee by other speakers that I've heard. And we do have the machinery in Canada to make that happen. We have CIHI, we have FAC, we have ISIS with all their methods of data management. So we have to collect data about what is happening in every sport in the country. We simply don't have that information, and we should. We should know how many people die from the annual coroner's reports. Now, those take 3 or 4 years until they're finished, but we should be compiling that data. There was recently a death in PEI of another rugby player. And so who's adding up all those catastrophic injuries? Well, that should be a national effort. And we've heard about, good resources that are available, like the one I held up, Canadian guidelines on concussion in sport. This should be in the hands of every family, of every coach, of every referee. So I would like to see your committee doing something about distribution of what is already available. I think Canadians have done a very good job of preparing a menu of opportunities for your committee to distribute and emphasize. And I would encourage you to use what's available rather
Thank you,
than.
Dr. Tater. Thank you. So we're going to be moving over now to the Liberals. We're fortunate today that we have the chair of the Standing Committee on Health to be with us here today, and that's Mr. Casey. And thank you for launching this subcommittee, Mr. Casey. And the floor is yours for the next 3 minutes. And I understand you may be sharing your time.
I'm going to share my time with Dr. Elson. Yeah, you actually answered part of my question, Dr. Tater, because I know a while ago, a few years ago, there was a concern about brain tumors, and doctors had no information about what was going on in other locations, and there was no brain tumor registry. And we passed a bill in Parliament to establish a brain tumor registry so that if there was a cluster of brain tumors in one location, they could compare the circumstances to see if there was some common denominator. And it sounds like that's what's needed here as far as concussions, so that there is a registry and study done that researchers themselves can compare to see if there's a common ground or common denominators. Would you recommend that?
Absolutely. That really makes sense to me. If we documented carefully all the concussions that are occurring in the country, especially in sports and recreation, we can do that. We have the organizational ability to do it. We have the CIHI, we have ISIS, we have FAC, we have all of those great opportunities available to do the math and count up how many are occurring in rugby, how many are occurring in hockey, how many are occurring in soccer. Then we'd find out how important heading the ball is in soccer. Like we really suspect that it's an important cause of brain injury in some people. Well, this would be the way to make sure that we get early warning in our country. We want kids to play sports, but we do want them to play safely, and that will keep them playing forever. That's the motto of Parachute Canada. Play safely, play forever.
Dr. Elson?
About 45 seconds.
Okay, sure. Yeah, very quick one. Thank you. We were talking before, Dr. Tater, about the studies you've done on brains, and there, if you and I know your sample size is not really large, but had you found any of these, where you had athletes who'd had a number of concussions but had no symptoms? Because there are people who recover; they'll have multiple concussions but no long-term clinical presentations. Was there any correlation you found where you'd have less of these tau proteins in the people that had less symptoms or more? Or did you see some of these in people who really had no long-term symptoms?
You know, those are all great questions, and we can't answer any of them accurately with our small sample. We said this before, that we need about 200 brains in order to answer those questions. And there are some big gaps in our knowledge. For example, we just received the first woman's brain. All the other 44 brains that we have accumulated over the past 10 years have been male. And that's the same with most registries. There's a real lack of women's brains. We put out a big advertising campaign to try to get women to donate their brains. Ultimately, you know, when they're finished with them, give them to us for science. So
we're going to move over. On that note, we're going to move over to the Conservatives. Thank you, and Dr. Kitchen.
Thank you, and thank you again. After many years in dealing with sports and in my private practice, I was a trainer, and then my private practice, and then I was one of the team doctors for our junior hockey team for basically 25 years. And I noticed, and I reflect back today, and although I treated a lot of concussions over the years, it did not seem to be the same. When I was ending my practice, the longevity of the injury seemed to be greater in my last couple of years of practice versus my early years of practice. And I'd like to think that in my early years of practice, fresh out of school, I was on top of it and everything. And I'm wondering, from the research, can you tell us why we're seeing more situations where concussions seem to be going longer than 30 days? Is there any research, anything to suggest that? And I'll start with the researcher, Ms. Curran. Any comments that you would?
Well, as I mentioned, we definitely do know that more people have persisting symptoms than we initially thought. So symptoms like headaches, vestibular issues, which are going beyond the usual quote-unquote recovery time of a couple of weeks. And it's unclear whether that's simply because people are more comfortable reporting it and they don't hide it as much as they may have previously, or whether there is some other factor, extrinsic or intrinsic, which is emerging. And that is definitely something where research needs to be done more. We do know that women do present with persisting symptoms more frequently than men do. So the fact that Dr. Tater has only gotten one woman's brain for his research is very interesting. It would be very interesting to see more female brains. In terms of how long symptoms last, when people end up with persisting symptoms, they can become chronic. So that's a huge issue in terms of managing the people who end up with, in that 15 to 20%, who end up with a concussion that has persisting symptoms. That impacts people's lives thereafter. So the research we really need is to figure out what sorts of things we can do for those people and what kind of evidence we can find in the research to support people like Dr. Marshall who do rehabilitation with people with persisting symptoms.
Thank you. And I know I want to get quickly through because I have very limited time, so I'd like to get from both of you. Dr. Marshall, is it because we are more tuned to it?
You know, great question. The quick answer is don't know. What do I think? I think it's I think you're asking the question now if they had a concussion. I think we're old enough to know that previously concussions are dismissed. It wasn't even within the conceivable that people could actually have persisting symptoms. I think now that we ask, that we see them. I think society's also changed. I think we actually talk, people are on board all the time with thinking these sort of things with regards to, technology and these sorts of things which can perpetuate symptoms. But I think it's because we're more aware of it. We're actually asking the question, whereas you were almost vilified before if you actually said you had symptoms afterwards. It was almost blame the patient for actually saying that you had ongoing symptoms because no one would ever believe you. And we have many examples of this through healthcare and through insurance industry trying to minimize these things.
Dr. Tater, quickly, I've probably only got about 20 seconds, 30 seconds.
Yep, that's it.
My take on it is that the forces on the brain now in certain sports are much greater than they were. When I played hockey, I was an average sized player. Well, now I'm a shrimp in comparison with the current crop of hockey players. So the forces that they generate is much greater. because they're greater weight, they're skating faster, for example, because they're longer legs than I could ever skate. So the forces, like what I learned from Pat Bishop, is that force is a very important factor in the impact on the brain. So that's another reason why they're lasting longer, because they're more serious.
Thank you. And we're going to move on to our last question, and that is Ms. Hardcastle for the NDP.
Thank you. I guess just to wrap up then, can we go back to some of the research opportunities that we need to really be exploring about our understanding of the gender differences?
So, yeah, I know that in terms of what's been done, there's a lot more focus that's been put on to men, and a lot of male varsity teams, male rugby teams, that sort of thing have been part of the research literature. It's starting to emerge a little bit more now that women are coming into the research and that people are becoming aware that there are gender differences between the way women present with things and the way men present with things. So I think that that is promising. It needs to really become a little bit more of a focus, because certainly in terms of the people who present to Dr. Marshall's clinic, for example, we know that 2/3 of them are women. And that's a huge impact to that segment of society.
Dr. Marshall?
Sure, I can comment. First of all, I'd like to just, if the committee hasn't interviewed Dr. Angela Colantonio, she actually has a CIHR grant looking at gender differences in brain injury and concussion in particular, and she's just an expert and an excellent resource. I can say definitely more, in my clinic, 2/3, 70% of our patients who have persisting symptoms are women. Their injuries are different, they're managed differently. I also think we have to do a lot of psychosocial implications of this. I can also comment that my clinic isn't just sport concussion related. I see a lot of concussions outside of sport. And if I had one message too, particularly for if we're looking at adolescents, people, in university, sort of thing, sport has done so much for concussion, but there are people who have concussions because people are active, and concussion affects people who are active. People who aren't active don't get concussions. And the truth is, you can have it through even recreation, through things that we don't consider sports, rock climbing, these sorts, other things that weren't organized sport, but do get concussion. I think we have to, that awareness does occur. People playing on the playground get concussions. So just to mention, and certainly exactly the focus on gender needs to be researched. Women absolutely behave differently in relation to their response and in treatment to their concussion.
And Dr. Tater, is that something that you recognized early on that you'd like to see see treated aggressively with the research?
Yes, absolutely. Trying to determine why women concuss more easily and why post-concussion syndrome lasts longer in women are questions that we are grappling with. In fact, last year we had a full day symposium on concussion in women and girls. And there is now a worldwide movement called Pink Concussions that we've joined forces with. And that group is also trying to find the answers. One answer that does appear to be firm is that women have less well-developed neck muscles. And strengthening neck muscles may prevent the jiggle of the brain within the skull that causes concussion. So the stronger your neck muscles are, the less jiggle of the brain if you get hit with a soccer ball or if you fall while skating. So strengthening neck muscles is a very attractive way to try to protect women from concussions.
Thank you. And that will conclude our hearings for today. We want to thank Ms. Curran, Dr. Marshall, Dr. Tater. Thank you for all of your answers. And with the papers, research that you've done, anything that you would like to submit recommendations, please to our analysts, feel free to do that. That would help us a lot. You also mentioned a Dr. Anthony or Dr. I didn't catch the name of the...
Antonio.
Antonio. Dr. Antonio?
Colantonio.
Colantonio. If we could get also that information about Dr. Colantonio, that would be terrific. And thank you for the legacy that you have built up here for Canada when it comes to concussions. Thank you so much. And that will conclude our meeting. Thank you.